Dear colleagues, thank you for joining my presentation. This is me, Maythem Al-Fartousi, talking to you today about the root canal obturation as a crucial component of the root canal treatment that is necessary for the success of the root canal treatment and for the long-term prognosis of the tooth. The following points outline the presentation protocol. We're going to talk about the reason of the root canal treatment, then the timing of it, the working length, the commonly used materials, and the future of these materials. And then we'll talk a little bit about the different techniques of filling the root canal system. Here we'll talk about the importance of the obturation. As we know, the dentinal tubules serve as conduit between the pulp chamber and the outer periphery. This allows nutrients and fluids to exchange and move between the pulp and the surrounding tissue of the tooth. If we end up having our root canal treatment without obturation, the bacteria and the microorganism will find their way to the pulp chamber, causing reinfection, ending up having failure of the treatment. Beside that, there is very important historical study talking about outcome of root canal treatment given from NG and her team in the year 2008. It was published in the year 2008, talking about 4 important factors that may affect the outcome of the treatment. The first one is, before we start the root canal treatment, if we have apical lesion or if you don't have apical lesion. If we have apical lesion, we'll end up having success rate up to 74%. If we don't have this apical lesion, the success rate will be over 95%. The second point was the obturation must be voidless. If we have voids inside the root canal system, the bacteria will find their way inside to the pulp chamber, to the root canal system, and this will cause failure. The third one, the working length must be determined. The filling, the depth of the filling, the terminal point must be adequate to the determined working length. And finally, the corona restoration must be sealed, must seal the tooth. Otherwise, if you have leakage for bacteria because the margin is not sealed enough, we may have failure. For the timing of the treatment, it's important to understand that when we have the root canal system shaped, cleaned, and disinfected, and the patient is willing to maintain opening his mouth, and they still have the power to finish the treatment, so why not finishing this in one visit? And then in a youngest publication talking about this topic, giving from Merjoni and his team, published in December, I think, 2022. They gave a systematic review and meta-analysis talking about the single or multiple visits. They end up having the result that there is no evidence of superiority of one treatment over the other one, of finishing it in a single visit or in a multiple visit. So we have sometimes patients coming from far away to our office for having endo. It's better for them to have it in one session. So if I am able to clean and disinfect and having a dry canal in the first session in one treatment, so why sending patient back home and calling him back for another appointment? So there's no problem if you finish the treatment in one visit. So the depth of the root canal filling must end there where we have the apical constriction, not where we have the apical foramen. The distance between these 2 points is somewhere between 0.5 to 2.4 millimeter. We have some variation of the apical constriction. We may have multi-constricted area, and if we have multi-constricted area and we end up filling the root canal system up to the first constriction that we reach, we may leave untreated area, space in the root canal system, and if you have infection there, we are not going to have healing. The patency principle is very important, because if we advocate this principle and do our first instrumentation simultaneously with the apex locator, we are going to jump from the first constriction to the next constriction, ending up having the right measurement of the walking length. So sometimes it is, the problem is we can't see this multi-constricted area in the radiograph. That's why it's important to have the apical patency. So the walking length must be determined up to the last constriction before reaching the apical foramen. Usually the root canal fillings consist of gutta percha points and sealer. The gutta percha points are obtained from gutta percha tree. The raw material is treated so that the material consists of 20% gutta percha and 65% zinc oxide, and then 10 to 15% of pasifurin fillers. To the sealer, we have many sealers on the market in the world. The most commonly used sealer in the world are outlined with these 5 sealers. The zinc oxide eugenol sealer is very well known in USA and commonly used there in USA and South America and North America, maybe South America as well. The epoxy resin sealer is very common in Western Europe, especially here in Germany. We have calcium hydroxide, silicone-based sealer, and calcium silicate. The calcium silicates such as MTA and bioceramic sealer are now the new hype. Not very new, because it's mostly more than 10 years old. The bioceramic sealer, for example. Unfortunately, we still have no perfect sealer. Every sealer we counted in the previous slide has a side effect. We are going into detail in the next slides talking about each side effect of each sealer. Zinc oxide eugenol cement has very long setting time. The measurement of setting time that is written in the instruction of use supplied with the pack is in vitro, not in vivo, and usually in vivo it takes much more time to get the material set. This is not specific for this material, this is for every sealer on the market. They write down the setting time that is measured in vitro, not in vivo. The second problem with this material is the cytotoxicity. It's cytotoxic and it's stained. It's stained if it is not well removed from the canal during the revision, the retreatment. So, as well as the zinc oxide eugenol cement, the epoxy resin sealer is cytotoxic. If extruded, a foreign body reaction will appear and it stains. It causes discoloration. The third one is the calcium hydroxide sealer. The manufacturer of this sealer make claims about the ability of this sealer to promote cementum formation. But unfortunately, there is no enough evidence support this claim, so that not only the cementogenic function, but also the osteogenic function is not supported by scientific. The idea of the silicone-based sealer is not bad, because this sealer has the property that during the setting time, the material expands. Through this expansion, the space between the gutta percha core and the wall of the root canal system will be well sealed. Still very difficult to handle sometimes, and it is limited only to cold obturation, single cone system, single cone obturation technique. And unfortunately, many studies have shown no antimicrobial properties of this sealer. So this is another disadvantage of this material. So the last one in the list is the calcium silicate sealer. The manufacturer of this sealer recommend only using cold obturation technique with this sealer, because they claim that using heat may evaporate the water components in the sealer. This causes voids in the sealer, leading to empty spaces between the root canal wall and the gutta percha point. Many studies support using calcium silicate sealer with the vertical compaction technique, warm vertical compaction technique, only if the sealer is pre-mixed and coming in the ready in the syringe. If it is not pre-mixed, this is not favorable for this kind of technique, for the warm vertical compaction. That's why I think it's okay if you want to use the warm vertical compaction with the calcium silicate sealer, but you have to be aware that using the non-premixed one, like the BioRoot, may lead to voids and to empty space between the canal wall and the filling material. The second disadvantage is that this material is expensive, but it is a very good and well-researched material. I recommend use it. We spent the last 5 slides talking about the disadvantages of the sealer that represent the vast majority of the sealer on the market. But we still have solution for many problems. One of them is the nanotechnology. The nanotechnology has opened new possibilities for creating new materials with better properties, better performance. Also in dentistry, this technique has its place, and I think in the future the place will be bigger using nanotechnology. We will mention some of the advantages employing this technique, especially in our topics, the endodontics, or maybe in this specific topics of the endodontology is the root canal filling material. Per definition, the nanotechnology is actually the technique to manipulate the materials in the nanoscale level. The technique deals with materials that have at least one dimension. There are materials with 2 and 3 dimensions in the range of 1 to 100 nanometer. 1 to 100 nanometer, very small particles. The smallest units in the nanotechnology called nanoparticle. And these nanoparticles have variety of shapes. They may take the tube shape, they may come as wires or maybe nets, rods, and many other shapes. The most common materials used in the endodontic industry, I mean the nano materials in the endodontic industry, are the chitosan, silver nanopolymer, copper oxide, calcium oxide, and zinc oxide. These materials are going to be used. Well, they are already used, but there's still some studies have to be finished in order to put it in the market. But this one will be the future of the material in the endodontic industry. We will talk more about the properties of the chitosan added as a substitute to many sealers. As I mentioned, now we will talk about the chitosan nanoparticles. First of all, we extract chitin from the crustaceans, and with some chemical reaction we can alter the chitin to chitosan. Chitosan is well known with its property of antimicrobial. If we increase the surface of the material with the nanotechnology, we will achieve more effectiveness of the chitosan, and the altered material will be chitosan nanoparticle. Chitosan as nanoparticle is then in a small amount very effective, more than 400 to 500 times effective than using chitosan in non-nanoparticle and the macroparticle. This has many favorable properties if we use it with the sealer. It has high solubility in acidic environment. It has amino groups that dissolve the bacterial membrane, and it is very effective against Enterococcus faecalis. Enterococcus faecalis are well known that they are strong resistant to antimicrobial agents and Adding 1 to 2% of chitosan nanoparticle to AH plus or calcium oxide sealer strengthen the infiltration of this material in the dentinal tubule. This makes the adhesion of the sealer to the wall very strong, so that the possibility of getting voids will be very small. So we talked about the sealers and a little bit about the nanotechnology. In fact, the nanotechnology is still making researchers busy exploring actively the properties of many materials that can be used in the dental industry. They are investigating the development of these materials, of certain properties of these materials, such as the solubility, antimicrobial efficacy, antimicrobial effectiveness of this material, and the durability of the material. They are going to remove the expensive sealer from the market and to change it with material that is less expensive, easy to use, with better properties, and as I said, easy, cheaper for the end user, like the dentist or at the end the patient. So now we finished the part of the material. We will talk about the obturation techniques, different obturation techniques with the next slides. So now we are going to talk about the different technique. The most common technique is the cold lateral compaction. Cold lateral compaction depends on putting many cones inside the canals and compacting the next cone to the wall of the root canal, and then putting the next one till you don't have any place to put the new one. This one, as I said, very common and not that easy, has its limitation, because sometimes when you are compacting the materials to the wall and then removing the spreader from the canal, you may pull up the cones from the estimated walking length without feeling that you did that, and then you make your radiograph, and you'll get your surprise that the root canal filling is somehow a little bit short. The next one is the warm lateral compaction technique. This is a little bit difficult to use, difficult to perform. You put your cone inside the canal, you put your pack instrument down and the filling up to 3 or 4 millimeters, then you activate the pack instrument with heat and compact the material to the wall, and then putting the next gutta percha point inside it and compact it to the wall. you mostly going to end up having the whole material removed from the canal while you are removing the pack instrument from the canal. This is very difficult, not that effective. Some people there may be some people who like this technique. I don't like it personally. Then we have the single cone technique. This is very quick, very effective. You squeeze the sealer inside the canal, like bioceramic sealer, silicone based sealer, MTA. Then you put only one cone that has the same size of the shaped canal. If you prepare the canal up to size 35, taper 4, you may put cone that has the size of ISO 35 taper 4 inside the canal. You have to coat coat the cone with the sealer before placing it in the canal inside. Then you remove the upper part of the cone that is looking out of the orifice of the canal, and then you are finished with the filling. This is very, very easy. Has its limitation. It's not easy to use with every tooth, and sometimes we don't have round cross-section canal, so we have to be careful using the right sealer with this technique. So we have the squirting technique, which is somehow complicated. We go with the squeezing, gutta percha squeezing tip inside the canal, about 1 to 1.5 millimeter away from the estimated walking length. Then we squeeze the warm gutta percha inside the canal while we are removing the tip outside it. And then at the end we have to compact the gutta percha from the coronal part down. It is difficult to use. Sometimes we end up having short filling, and sometimes we have extrusion of the material of gutta percha outside the canal. I find it very complicated and I don't use it. I like personally the vertical worm compaction. There are many different techniques. We are going to talk about these techniques. I'll show you a video. We have the shoulder technique, we have the continuous wave technique, and some modification of both of them. So in this slide I will show you different warm vertical compaction techniques using heated device, plug-gas, and warm gutta percha fill device. This video has been trimmed, speed up, and edited from the homepage of VDW. It is important to mention that I have no conflict of interest mentioning the brand name of the devices, because I took this device from their homepage, so it's fair to mention it. Well, here we will start talking about the shoulder technique, which is in fact not that complicated. We insert gutta percha cone up to the walking length. We remove the excess gutta percha. Then we heat 1 to 2 millimeter from the gutta percha. We remove the excess gutta percha. We compact it with plug-gas. Then we repeat this till we reach the space that is 5 millimeter away from the working length, from the apex, and then we fill the whole room inside the canal with heated squeezed gutta percha. This is the shoulder technique. The modification of shoulder technique is that we insert the cone, we go with the heated device deeper till 5 millimeter from the working length, from the apex, and then we compact the gutta percha and we fill the space with squeezed gutta percha. And after that, we have the continuous wave. By the continuous wave, like here, we go with the device inside it, we activate the heat device, and then we turn it off, we press it a little bit down, and then we activate it back and pressing it down till we reach the 5 millimeter. This is the continuous wave. Continuous wave. That's why the name continuous wave. So this is the main work. After removing the gutta percha, we have to fill the canal with the squeezed gutta percha, and then we compact it a little bit from at the orifice of the canal, and this is it. We are finishing. We are finished with the obturation. If you have questions, don't hesitate to contact me on Facebook or write down a comment, maybe here in YouTube. Thank you for joining me today, and have a nice day.